Can you all hear me? Okay, so welcome to this afternoon's IBD GECO meeting. This is our fourth or fifth, I believe, and I think they've been quite successful. So GECO is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. These sessions are held on a weekly basis. Our IBD one is held once a month. And today we have 81 registrations from 15 countries, which is fantastic. Just to say, please post questions on the chat, or even better, in person. So just briefly, today is going to be a session really of complicated Crohn's disease. And we have two great speakers. Our first is Professor Machiko Setshedi, who's head of the Division of Gastroenterology at the University of Cape Town and Groote Hospital. And the second is Professor Awuku from the University of Health and Allied Sciences in Ghana. So Machiko, if you want to start off with your presentation.
Sure, happy to. Thanks, Jill. Can you see my slides? Oh,
yeah.
Yes.
Okay, thanks. Good afternoon, colleagues. Thank you so much for the opportunity to present. We've had a lot of patients coming through with small bowel intestinal obstruction as a result of ileal or ileocecal Crohn's disease. And I thought it's an opportune moment to review this topic because I still find the diagnostics challenging, as well as how you manage individual patients, because indeed no therapies are the same for every patient. So what I was planning to do was just to do a broad overview of the topic. This is not going to be a comprehensive of every aspect of the topic, which is quite complex. But really just to set the scene, hopefully for discussion as to how others understand the guidelines and as to how you all manage your patients and the challenges that you face. So I'm going to start off with a patient who's very well known in our unit, and he's been coming in and out. And his most recent admission, I think, was about 2 weeks ago. So he's a 56-year-old male. He was diagnosed with Crohn's disease, ileocecal phenotype in 1986. He's had multiple previous small bowel resections. And now more recently, he has evidence of a neo-TI stricture and presents with intermittent small bowel obstruction. His disease is poorly controlled with 6MP, and he's got a bunch of other comorbidities to go along with his IBD. He has gout, he's got kidney disease, he's got NASH. He has been struggling with smoking for many years, but has recently, in the recent past, stopped smoking. Part of the reason for his management difficulties was that in the past, he wasn't able to stop smoking altogether. And when the issue of whether he was eligible for biologics or not came up, the smoking issue became quite a serious confounder. So on examination, well, he complained of 4 watery loose stools, intermittent vomiting and abdominal pain. The main findings on examination were that he was pale, and actually he had lost quite a lot of weight, visibly lost a lot of weight. His biomarkers are shown there. So he's anemic. He's got chronic kidney disease with a creatinine of 155. I'm just going to move the camera here. Yeah. And he's got a raised alkaline phosphatase, all in keeping with the steatosis. And of course, you have to consider other possibilities. His CRP was normal at 4, and his fecal calprotectin was just very modestly elevated with a cutoff of 50. So he had an MRE done in 2019, but this CT scan was done recently this year in April. And I don't expect you to read all of that, but basically the report said that he had long segment neoterminal thickening with luminal narrowing, extending a distance of about 20 centimeters. And they said that he had surrounding fat stranding with a comb sign due to vascular engorgement, and the features were consistent with long segment, and they committed to active neoterminal ileal disease, but with mild upstream dilatation. He had no abscesses or fistulae or nothing else that would be relevant in sort of managing this patient. And what I'm trying to show here is that you can see that this is the neoterminal ileum, quite a long segment, 20 centimeters of stenosis, luminal narrowing, bowel thickening. And you can see some pre-stenotic dilatation. So that's the first patient. If you can indulge me, please, we're going to put up a poll. How would you manage him? So would you increase his dose of 6-MP, start methotrexate, start him on steroids, IV or oral, depending on how severe you assess him to be? Would you send him to the surgeons for a resection or start him on a biologic? I'll just give it another few seconds. So it looks like the majority are favoring a biologic. So about 80% a biologic and about 20% resection. Okay. So I'm just going to stop the poll there. Cheryl? Yeah, that's fine. Let me come on to the next patient. He's now currently admitted. He's a 58-year-old man. He's been diagnosed with Crohn's disease in 1999. He had a TI resection in 2001 and then again in 2009. He had been treated for latent tuberculosis 7 years ago, at which point, unfortunately, he stopped coming to the clinic, was lost to follow-up. After that time, he took his azathioprine for 4 years, and then it didn't make him feel well. So he had a bit of a vague abdominal discomfort and pain, so he stopped taking it. So for the last 3 years, he's been off any medication and has been virtually asymptomatic. He's an ex-smoker who stopped in 1999. So he recently represented, complaining of low abdominal pain. And because of the severity of the cramps, he had already put himself on a liquid diet by the time he came to see us, complained of 5 to 6 loose stools. He complained of a 10 kg loss of weight. On examination, he also was pale. And in fact, he had lost more weight than he reported. He had lost about 20 kg. Again, he was anemic. He had normal renal function. The albumin was almost normal. Well, the alk phos was slightly up. The CRP was up. And the fecal calprotectin compared to the first patient was quite significantly elevated. So now he had an MRE. So when he came the first time around, so about 7 years ago, he had an MRE which showed that he had a 4.5 centimeter stricture. And then of course he was lost to follow up. And now on this current occasion, the MRI showed evidence of previous TI resections. And this time he had approximately a 7 centimeter fibrostenotic segment. And basically because of the marked pre-stenotic dilatation, the radiologist called it and said that he had more features in keeping with fibrostenotic disease than inflammatory disease. And in fact, this was discussed at our fortnightly MDT meeting, and they felt that the inflammatory component wasn't that impressive. So the final question of the poll is, how would you manage him, this second patient? Would you put him on steroids? Would you restart his azathioprine? Again, would you send him to the surgeons? Would you start him on a biologic? Or would you even consider something like endoscopic balloon dilatation? So we're getting some spread between surgery, a biologic. I'm just writing this down because we want to come back to this, and EBD. So just about, yeah, so 1 in 5 of you think surgery, even steroids. So it's quite a spread. All right, so the point of these two cases is really not that there is a perfect answer. It's really, as I say, to try and encourage discussion. And then at the end, we can have a chat about what we did, whether that was the right thing or not, and what you would do in the situation. All right, so as I said, I'm just going to briefly then just talk about fibrostenotic Crohn's disease, and basically the characteristics of ileal Crohn's disease. We know very well that phenotypically and in the way the patients present, in the way the disease is endoscopically, histologically, etc., it is very different than colonic Crohn's disease. I mean, we know already from the heterogeneity that you have a penetrating phenotype, a structural phenotype, even mixed, etc. So we know that it is an entire, it's almost like an entire disease all by itself, even within the realm of IBD. So inflammatory phenotype is commonest, particularly at the time of diagnosis. But there's no question that about 10% of patients, even at the time of diagnosis, will have a stricturing phenotype. And I think that's an important point to make, that when the patients come, they may already have evidence of bowel damage. And the strictures themselves can be inflammatory, fibrotic, or mixed. And I think the distinguishing features are not necessarily easy or easy to make. And then we know that probability of progression to stricturing disease increases with time. And we've all seen the slides 1,000 times over. We know that over a 10-year period, 15% of patients develop stricturing disease. And if you double that time, about 20% of patients will have stricturing disease. So here you've got the inflammatory component, and the patients present with flare and remissions, etc. But over time, cumulatively, progressively, you get damage to the small bowel, you get stricturing, fistulae, abscesses, phlegmons, surgery, and then even redo surgery because of the recurrence of these strictures. And it's also important to know that overall, up to 70% of patients will require surgical treatment for a complication at least 10 years after diagnosis. And in fact, the chief reason for surgery in these patients is strictures. Obviously, abscesses and fistulae are other reasons that one might perform surgery. Post-op recurrence is very common, and we all know the risk factors for that, with the increasing need for redo surgery. But also important to note is that when there is stricturing, look out for fistulization. The two may coexist. So this is data from a retrospective study that showed that in patients who had stricturing disease, the positive predictive value for fistula formation, usually below the pre-stenotic dilatation, was 86.2%. So the two are not mutually exclusive and may very well occur together, and these are the features that you should be looking for on radiology. So fibrostenotic disease specifically refers to persistent luminal narrowing, and it can include obstructive symptoms, although this is not universal. So some patients may have quite severe narrowing without any obstructive features, and it's seen in about a third of patients with Crohn's disease. I'm not going to go too detailed into the mechanism of fibrosis, but basically it is induced by inflammatory activity with the induction of the immune system and the release of pro-fibrotic cytokines. But you also have non-inflammatory components with mesenchymal cells and other cells that are activated to lay very deep collagen in the tissue, essentially causing a lot of fibrosis in the deep tissues. It was thought at the beginning of anti-TNF therapy that because the anti-TNF therapy would cause a rapid healing of tissue, that would result in rapid scar formation, but that has since been refuted. So there absolutely is no correlation between the use of anti-TNFs and the development of fibrosis. And as I said earlier, even early after diagnosis, or even when you see the patient or when you start the patient on therapy early on in disease, there may already be a structural damage. So the inflammation-dependent and independent mechanisms seem to be at play here. And I think this is an area of intense research to try and understand what the mechanisms of fibrosis are. What are the soluble factors that perhaps we could target as therapy for the fibrotic nature of the condition? I mean, at least we still have a lot of armamentarium to use for the inflammatory component, but not much really for the fibrotic component. The risk factors, it's important to note, as I said, that this kind of disease is specific. So patients who have NOT2 mutations of the ILR23 autophagy genes, even some epigenetic markers are at higher risk of fibrostenotic phenotype compared to patients who do not have these markers. So there's a genetic basis for risk. And then if you look at data from the TREAT registry and the ACCENT-1 trial, they showed that the longer duration of disease, the severity of the disease, the earlier location of the disease, and use of corticosteroids are all risk factors for developing fibrostenotic disease. Infliximab, as I said, is not a risk, contrary to what we initially believed. And what is protective is if you have a colonic disease. The diagnosis, so to make a clinical diagnosis, the patient may or may not present with obstructive symptoms, so postprandial pain, cramps, discomfort, nausea, vomiting. Patients are well aware with their condition, so a lot of them know exactly what the triggering food might have been that causes obstruction, and already by the time they come, like in our second patient, they've already modified their diet. But as I said, the symptoms correlate very poorly with the presence of a stricture. And in fact, even a patient who has a fistula may present with what sounds like obstructive symptoms. Now, there's a group called, they call themselves the Constrict Group. So it's a group of international panelists from all over the world who were trying to find definitions so that we can standardize definitions for endoscopic features of a fibrostenotic stricture, as well as radiology findings. And basically the definition they came up with was a stricture is when you have an obstructive lumen that cannot be traversed with a standard adult colonoscope, where you haven't prior done dilatation and using reasonable amount of pressure, and you are unable to traverse that. That is what you call a fibrostenotic stricture. And it is important when you do endoscopy to take biopsies to rule out dysplasia or malignancy, noting, however, that if the biopsies are superficial, you might miss picking up on these abnormal cells. And diagnostic modalities to diagnose the strictures and the other features of Crohn's disease, so the fat changes, dysplasia, cancer, perhaps, wall thickening with stratification, so layering on CT or MRE, strictures, abscesses, all of these are things that can be readily appreciated on the cross-sectional imaging. And what you can see here is that compared to the gold standard, which is histology, the sensitivities and specificities for the different modalities are quite high. Ultrasound really in a situation where you don't have access to CT or MR, but basically CT and MRE. So even though CT scan has got 100% specificity and sensitivity, both of these are quite accurate in delineating the strictures, but MRE is preferred because of the lower risk of radiation. And again, the Constrict group came up with features that you would look for at imaging to try and diagnose this problem. So basically, we're looking at the luminal diameter, and if it's less than 10 millimeters on ultrasound and CT, or less than 50% narrowing, and then you're looking for pre-stenotic dilatation, as stated there, as well as the thickness of the wall. So those are the three features that would be helpful in trying to determine whether this is a stricture, how long it is, and if there may be inflammatory components in the stricture itself radiologically. So here's an ultrasound image. That a bright layer there is the wall thickness. The L represents the lumen, which is reduced in size, and the D here represents the pre-stenotic dilatation. And you can see that also on MRE. So this is a axial section, this is sagittal, this is coronal, and you can see here very nicely a stricture in the terminal ileum. You get stratification or layering with bright hyperintense areas and less intense areas, narrowing, thickening. Here you can see on axial cuts just how narrow the lumen is and just how thickened the bowel wall is. Here you see dilatation, which is quite enlarged, and you've got different views using different sort of types of radiological images and tools. And again, you can see hyperintensity, wall thickening, and features that are quite suggestive. Here you can see mesenteric engorgement, which looks a little bit like a comb. So that is the comb sign, suggesting more of an inflammatory component. I had more pictures here, but I'm just going to skip it. I don't want to take too long. And then there are other novel imaging techniques, such as transfer MRI, MRI with dynamic contrast, ultrasound elastography. I think we're going to see a lot more on this, but currently the guidelines do not suggest their use in routine practice. It is important to talk to your radiologist. The patient needs to take the contrast. You also need to take antispasmodics because that can affect interpretation of the images. So the management generally of a patient who presents with obstruction, obviously they require admission. It really is an MDT approach with the gastroenterologists, colorectal surgeons. We work very well and closely with them. We co-manage the patients. Radiology is you can't do without it. And then obviously pathology, you need dietitians. These patients are usually malnourished. Obviously you will investigate for a flare and obviously any other potential problems like an infection and other reasons for the presentation, including biomarkers for inflammation. You need a chest X-ray, abdominal X-ray. I've mentioned the importance of cross-sectional imaging, endoscopy, because this is how you'll know what is happening endoscopically, and of course you'll be able to take biopsies. And then to manage the small bowel obstruction itself, the patient will go nil per os fluids. Don't forget to supplement electrolytes, NG tube, etc. And as I said, the role of the dietitian cannot be overestimated. Don't forget to treat anemia, B12. So during COVID, we ran out of B12 stocks. And then what we were doing was that we were actually measuring B12 levels before deciding on giving a patient an injection. We now have got our stocks and we've moved away from this for this sort of patient. This patient requires B12 injections, even if their levels seem replete, because of course, if you don't top them up, then they will become deficient. So that's very important. And then we have to decide on the definitive treatment of the ileal disease, which I'll come to in the next few slides. Once the patient is discharged, irrespective of how you managed the fibrostenotic disease, you need to give patients dietary advice, particularly if it's the first time. Obviously low residue foods to avoid grains, etc. And then patients need to stop smoking. I think that is non-negotiable. Very easy advice to give, but very difficult, of course, to achieve. And then, of course, then there's the decision to be made post-operatively, what medical therapy the patient may or may not need, how you prevent post-operative recurrence, etc. And then I think because of the risk of recurrence, you definitely have to monitor your patient closely. And then the medical management, obviously, if there's a suggestion based on your biomarkers, your histology, your cross-sectional imaging of an inflammatory component, we use steroids. Now, steroids are widely used, but in fact, the data is lacking for their use. So in a study that was done where they looked at 26 patients who were given steroids presenting with acute small bowel obstruction, they gave steroids in addition to IV fluids, nil by mouth, TPN, etc. So it's a confounded study already. But out of those 26, 25 of the patients, they got relief of the obstruction at 72 hours. However, of those 25, 75% developed recurrence or presented again at 52 months. And half of those responded to a second dose of steroids. Ultimately, in this cohort, when they were followed, about 40% of patients required surgery ultimately. So it seems that the role of surgery may be to relieve acute obstruction, but also perhaps to delay surgery, but not in half of the patients. So it has a role, arguable. We can have a discussion about that. And I guess, as I say, it depends on whether you're convinced for the evidence of inflammatory activity or not. And then in a RCT of 72 patients, who were randomized to azathioprine or mesalamine, azathioprine was superior. There was a lower rehospitalization rate and lower recurrent subocclusion. So it does have a role. Infliximab, so I found 4 studies that have shown efficacy, safe, and as I say, there's no such thing as promoting fibrosis due to healing. These drugs are safe and effective and should be used. There is a study, the CREOL study, which showed, again, efficacy of adalimumab with half the patients being surgery-free at 4 years. I haven't found any data for ustekinumab or vedolizumab. Jill, we can have a chat about that if I've missed on some of that data. And then what do you do with the patient? So you give general management, supportive, etc., medical management if appropriate, but really you have to deal with the problem. And in a case where there's persistent obstruction or failure of medical therapy, the options are balloon dilatation, stichuroplasty, surgical resection, and sometimes even a combination. So you might do one modality and have to follow it up with something else. And really depends on the characteristics of the stricture, the patient in front of you, obviously the the surgical prowess in the hospital that you are at, whether the patient has got an infection on board, etc. So there are many factors, patient preference as well. There are many factors to consider. So if you look at EBD, the indications are a stricture which is less than 5 centimeters in length. You can do it on naive as well as post-op anastomotic strictures. Ideally, it must be in an area that is straight and readily accessible, endoscopically not angulated. And what you need to consider is whether you're going to go anterograde or retrograde. So obviously, if you can pass the stricture with your feeding tube or guide wire, then it may be possible then to inflate the balloon distally and then pull it back. But if that's not possible, then you can dilate the balloon in front of the stricture and then push and try to dilate the stricture that way. There are other things to be considered. Intralesional steroid injection is not recommended. You must biopsy to rule out malignancy. And biopsies pre-EBD do not increase the risk of perforation. However, they may be associated with the reduced success of the EBD. Contraindications are complicated disease with fistulae and abscesses. Obviously, if there is underlying malignancy and other more generic risks for performing endoscopy. The potential complication risk is about 4% with bleeding, perforation, and infection. The outcomes are generally good. So the technical success rate is about 90% with an efficacy of about 80%. And what you can see is that over time, the rates of symptom recurrence, the need for redilation, and even the need of surgery goes up. So again, similar to steroids, they sort of buy you time, but that might be important in a particular patient. So I'm not suggesting that you should do surgery on all patients. These are modalities that can be used with good success, and they may also offer you the ability to temporize while you're looking for a more definitive approach. So stricturoplasty is bowel sparing. So you try to not resect what is left of healthy bowel within that area of stricturing. It has contraindications as listed there. The problem is that you get recurrence, but interestingly enough, not at the site of the stricturoplasty. The stricture forms in another site. And the way that is done really is that the surgeon makes an incision here and then sutures sort of longitudinally to try and preserve as much functional mucosa as is possible. This, I think, if I'm not mistaken, is not advised for colonic strictures. All right, and then surgery. The most important thing about surgery is that it really needs to be done early. So if you have a patient who even presents for the first time and you're convinced that this is this phenotype of stricturing disease, and depending on patient factors, et cetera, this might be an option even early on in the disease. May not be the case for other types of patients, but it's something that certainly should be considered because it is most effective when done early in the course of the patient's disease. It is associated with longer clinical remission, decreased risk of repeat surgery, decreased exposure, of course, to steroids and other therapies that may be toxic or associated with other side effects. I've always heard of this creeping fat. I've never seen it. So when I found this on Google, I thought, if you don't know what this creeping fat is, which you can actually appreciate on the cross-sectional image, you can see this is a normal sort of uninvolved, uninflamed segment, but you can see how the fat actually creeps over the serosal side of the affected bowel. So I think that's quite nice to see graphically, so that when you see the Crohn sign and other things represented radiologically, you might have a better understanding. There are other lesions that have been tried. There's a meta-analysis, I think with one trial using intralesional steroids, stents, cutting techniques. I think all are still investigational and definitely not currently recommended as part of routine practice. So the challenge in this field is that we need to develop and evaluate the antifibrotics and see to what extent they can reverse some of the fibrosis and the bowel damage that patients have. We need to develop standardized diagnostic criteria, and in a way, the Constrict Consortium is trying to do that, but I think a refinement of this needs to still happen. There are many scores for inflammatory activity, the CDIA and the other scores. A Lehman index for bowel damage was developed, but it's quite cumbersome. So you You take a section of bowel, you divide it into segments, and then you score for stricturing disease, penetrating disease, whether there was resection, you come up with a cumulative score. You have to plot it for correlation to see what are the chances that the patient actually has got structural disease. It's not friendly. It's not something that you would readily use in the clinical setting, but it is something that we can use to try and assess cumulative and progressive damage, bowel damage over time, so that we can try to understand the complications of that. So coming back to our patients, so you'd remember the first patient was the gentleman who had had multiple bowel resections. He was on 6-MP. He had just recently stopped smoking, and he had radiology report that was consistent with inflammation, so active disease. And I think 75% of you said that you would give him a biologic, and 15%, I think it was 19% said that they would send him for resection. So the problem with increasing the dose of 6-MP is that it will take time to work. And if we are convinced that he's got inflammatory activity, then that is not optimal. It is notable that his CRP, his fecal calprotectin was only 60 something, but he might be that patient that doesn't necessarily mount an inflammatory response in the form of the fecal calprotectin. So if you're going to choose a marker to use to follow up, maybe the fecal calprotectin in him might not be the best marker. You can't start methotrexate. This gentleman has got steatosis. I showed you already, he's got abnormal LFTs, etc. Steroids are an option, but he had been coming over, I don't know, for a while with these episodes, and he probably has had more courses of steroids than we need. And also, if you're thinking definitively in terms of resection or something, then generally our surgeons don't want steroids on board because of the tissue breakdown and other problems. So, that's not incorrect, but you need to consider those factors. Resection, again, is a problem in him because remember, he had a 20-centimeter long stricture. He's had multiple bowel resections before. So he's at risk of short bowel syndrome and the associated complications. So you have to think very carefully about how you can preserve some small bowel in this gentleman. So in the end, we went with the biologic. We were able to successfully motivate for him to get Amjevita, the biosimilar. He had stopped smoking. So this is what he's on. Yeah, we're monitoring him to see how he will do. And then the second patient, you'll remember, is the man who also had 2 resections. He had stopped smoking some time ago. His radiology was more in keeping with fibrostenotic disease, although his fecal calprotectin was quite markedly elevated. In him, he had a 7-centimeter stricture, and again, in an attempt to preserve bowel, given the fact that he's had previous resections before, the initial decision by the surgeons were that they're going to attempt balloon dilatation. But this gentleman is quite obstructed. So even in the ward on a liquid diet, he couldn't tolerate the liquid diet. He had to be put on TPN, severe cramps, etc. So I think now, I'm not sure what is happening currently, but I suspect that they may be considering surgery in him. So final words is that just remember that fibrostenotic disease is common, particularly later in the disease, but don't forget that patients can present with it when you first see them. And it really represents bowel damage with poor outcomes. So patients have complications, so they have fistulization, they need resections, and even mortality. So it's quite a serious disease with very poor outcomes. You need imaging to help you diagnose strictures and associated complications. But as I said, I'm still not convinced that the distinguishing between the inflammatory component and the fibrotic component on radiology is that clear. Because as you can see, if you throw in the biochemistry, endoscopy, and whatever, then the picture becomes quite murky. And this is important because it does influence how you manage the patients. Early surgery, if you're gonna do surgery, you wanna get in there early. But I think, and what I hope I've shown is that really no size fits all. You really have to individualize your treatments for the patient that is in front of you. I'm happy to take questions or discussions. Thank you so much for your attention.
Mash, I think we're going over time quite a lot. So I think maybe you'll give his presentation and then we'll see if we've got any time at the end.
Sure.
You ready to go?
Yes, I'm ready.
Fantastic.
Great. Is my slide showing?
Yep.
Great. Thank you very much for the opportunity to share an experience from Ghana in terms of the management of inflammatory bowel disease, and for today, specifically on Crohn's disease. I think Mashiko's presentation earlier on has answered part of my question that will follow, but I think it's still an opportunity to share and discuss in our unique environment in the management of inflammatory bowel disease. So I titled my presentation, Delayed Crohn's Disease, Diagnosis and Care Challenges. I have no conflict of interest. Show some photos of my patient. I have full consent. She is actually now an educator and advocate in Crohn's disease and tells me that some of the pictures she sent me are actually on social media already. Is more than happy for people to know about Crohn's disease in Ghana. So this is a 31-year-old female who presented with, he actually self-referred. He went on the online and looked out for any private facility with a gastroenterologist who will be able to help with her conditions. A 31-year-old female, she presented with progressive weight loss, multiple bowel surgeries on account of intestinal obstruction. She actually came not with a histology report, but with a sheet that has something written on it as histological diagnosis of Crohn's disease, and actually specifically Crohn's ileitis. She came with a medical report, and I tried to extract the following from her surgical notes. So here it was 30-year-old, that was 2019 when the surgery was done, who had intestinal obstruction, approximately died in December 2019. Surgery actually revealed a small bowel stricture according to her medical report. She had a second and third laparotomy on account of pelvic abscess. She also had resection of part of small bowel. And here, the part of the small bowel where there was a stricture reported a histological diagnosis of the Crohn's disease. He was referred to a second hospital for a fourth laparotomy on account of two perforations, one in the ileal region and the other in the anterior rectum, where a fifth laparotomy was actually done on this patient. This also broke down because they did a closure over the perforation, and so they went in further to do a resection of the perforated section and did an end-to-end anastomosis. Afterwards, they did a loop colostomy at the same surgery on account of an enterocutaneous fistula, which was actually noticed. This patient stayed in the hospital close to about 3 months and was discharged home for a follow-up in March 2020. She self-referred to a private facility where I work in July 2020. Later on, we had the surgery done to reverse the colostomy, and that was in October 2020. I decided to take a history from this patient prior to the surgery, what had actually happened. And apparently, she was well. After a physiotherapy session, she started experiencing abdominal pain. This was pain at the periumbilical area with intermittent radiation to the epigastrium and the right iliac fossa pain. Her pain severity was 8/10, was crampy in character. There was no aggravating factors, but it was relieved by lying flat. It was associated with vomiting, but no diarrhea. There was no passage. You could not pass any flatus nor stool at the time of her presentation. Her past medical history was very remarkable, and it has a lot of information that if you have the education on inflammatory bowel disease, this is the point where probably you think that there is something which needs to be investigated further. So she had intermittent mouth ulcers at the age of 18 years, which became persistent from the age of 25. She had bloody stool with crampy abdominal pain from the age of 20. She had general joint pain with severe lower back pain. It was severe such that they had to get a neurosurgical consult. MRI done actually did not show much, and they recommended physiotherapy from that point. According to the patient, she had had repeated blood transfusion from the age of 20. She was diagnosed with peptic ulcer. Many treatment episodes were done after an EGD. She actually had a right hemicolectomy done at the age of 21 years on account of an appendiceal mass. And in her report was also into bracket an abscess. The summary of her drug, family, and social history, I just picked up the key things. Had many antibiotics in the past 2 months prior to her presentation. After the surgery, she had actually been put on metronidazole for over a month. She had no known allergies. She was on multivitamin over the counter at her own, as her own self-prescription. She's a non-smoker. No known relative in the family has actually had any similar presentation. She's a graduate of a university with a human resource background and was unemployed. Her examination, her weight was 55 kg. She looked unwell. She was wasted with hair loss, as you can see in the picture here. Her respiratory, cardiovascular, neurological examination were unremarkable. Her GI examination also was unremarkable, except for a stoma at the right lower quadrant and many surgical scars on the abdomen. So baseline laboratory investigations that were done from CBD, BUN, creatinine, liver chemistry, CRP, thyroid function, gastroscopy, colonoscopy that were done were unremarkable, except for an internal hemorrhoid for the colonoscopy. The only abnormal finding in her baseline workup was a B12 level of 58, which was very low. So following this, the summary of her management is as follows. We put her on a 2-monthly follow-up to do CRP, CBD, LFT, BUN, creatinine, and serum calcium. We put her on Pentasa, 1 gram 12 hourly, calcium and vitamin D supplement. We also gave her vitamin B12 supplement. She got 1 milligram subcutaneously monthly. And we asked her to be able to retrieve her histology from the private facility where this report came from. So I'm just going to read the histological description here. It says that a section of ileum showed fissuring ulcers and abscesses and patchy transmural inflammation with lymphoid nodules and occasional granulomas. There are abscesses in the wall of the small bowel. And then it went on to also say, and then they made a diagnosis of Crohn's ileitis with that feature. Then there's the other part of the histologic finding, which says that there's a large bowel which show focal transmural inflammation, but largely the mesenteric lymph nodes were spared with reactive hyperplasia, but no significant abnormality. There's no evidence of malignancy, and he went ahead to conclude as a Crohn's ileitis, which I think is more of an ileocolonic disease. So the phenotype based on the age is the A2, L3, and B2 phenotype according to the Montreal's classification. So this patient was clinically stable until in December when she reported of severe right iliac fossa pain with low-grade fever. So we asked her to do an ultrasound from a nearby facility, and this was the ultrasound finding, the summary. It reported a non-peristaltic, thick-walled, incompressible bowel loop seen at the right iliac region, which measured about 1.42 cm in diameter. And it's also said the surrounding bowel loops are dilated with hyperperistalsis noted within them. So this definitely tells us that there's some form of obstruction. And with this description, most likely after the surgery, we're thinking something inflammatory and most likely not a fibrotic lesion. So we gave a remote instruction, the private facility nearby, to start 1 milligram per kg of prednisolone, to initiate azathioprine 50 milligram, put on omeprazole. Her response was remarkable. The pain resolution occurred within 48 hours. We followed up in 2 weeks at the clinic where he came in with a full blood count. Visceral LFT were normal. We increased the azathioprine to 75 milligram whilst we tried to taper off the prednisolone. So we discussed workout for biologic therapy, but our challenge was funds. Biologic therapy is available in Ghana in Fleximab and adalimumab, but the challenge is that it's out of pocket, and unless you have the money to buy it, you will not be able to get it. So we did a workup. There was a negative viral screen. The TB screen was negative. Varicella antibody positive. She had chickenpox at the age of 10 years. We also tried to do a COVID screen, including antibody tests. It was COVID naive. And then we started our fundraising activity by writing letters to many people who will be willing to help this patient. In February 2021, she came with a disease flare, same presentation, right iliac fossa pain with fever. The significant findings on examination was a temperature of 38 degrees Celsius, and it was a palpable mass at the right iliac fossa, and the pain was actually reproducible. So then we got a CRP, we requested for the fecal calprotectin. So CRP came in as more than 300 milligrams. Fecal calprotectin did not help in our decision to treat because we were able to get this report only after 2 weeks, because these samples are taken out of the country and feedback. I understand MDS Lancet are working through a private facility from South Africa. So it did not influence our decision as of the time. But based on the background history, the histology of Crohn's disease or ileocolonic disease, we took the decision that this must be a flare of the Crohn's disease. And so fortunately, we had gotten our funds for biologic therapy. So we initiated this in February. Her weight then was 60 kg. So we've done the induction dose, which was 300 milligrams, was given at time 0, 2 weeks, and 6 weeks to continue 8 weekly. She's only completed her induction dose, yet to get her maintenance dose, that is somewhere early June. We maintain her on the azathioprine 75 milligram. Her vitamin B12 workup came out as 461, has normalized. Patient was in complete clinical remission. We tried hard to see if we could get her to vaccinate for COVID-19. Unfortunately, we have not been able to achieve that. We're still looking out for opportunities. And I want anyone to guess. On the weekend, I told her about this presentation, and she had a complaint. And I want to know if anyone can guess her new complaint at this point. Interesting enough, this was her new complaint. The doctor, I have gained a lot of weight, and I want to know how best to be able to lose this weight. What is the way forward for my patient currently? We need to continue with our fundraising. If not, we will not be able to continue with the care that our patient is currently enjoying. I have some questions that I would need some opinion from other IBD experts on this platform. My question is, when do I stop the infliximab for this patient? How far can I push up the azathioprine? Any concerns with COVID-19? Advice, experience from other colleagues? Any special considerations for this patient? And our current challenge is that her new weight is actually 84 kg. And this implies that there should be an increase in the infliximab dose, which comes with an increase in cost. So our original plan for funds was going to be able to take care of 3 subsequent maintenance therapy. That is in about 6 months. But with this increase in weight, what it means is that we may be able to do only 2 maintenance doses as well. Any suggestions in case we exhaust our funds for infliximab and there's a need to continue? I would want to hear from other experts whether there are other plans for my patient. I want to say thank you to my team for putting a smile on her face. Her surgical scars all healed nicely. And she is actually an advocate for Crohn's disease, educating on social media, and recently just informed me that she's actually looking out, or actually set up a foundation called the Inflammatory Bowel Disease Foundation in Ghana to raise disease awareness and help others who may be suffering from same or similar fate. So in summary, Crohn's disease diagnosis is either missed or delayed, especially in Ghana. Access to diagnostics and therapy for IBD in general is poor. There is the need to actually improve access to IBD care. I think there's a need for IBD education or to increase IBD education in sub-Saharan Africa. And I want to thank this platform for the opportunity to educate and empower with knowledge, especially in the field of inflammatory bowel disease. Thank you very much.
Thanks, Yo. Can you stop screen sharing? Okay, so there's no actual questions from the chat group. So Yo, maybe you want to put up your questions that you mentioned at the end of your presentation, which was excellent, by the way, and so we can discuss them.
Okay. So
perhaps just go through them again with us.
Okay. So the first question is, when do I stop the infliximab for this patient?
That's a simple one, never.
Agreed.
I mean, obviously, it might not be possible in her because of the costs involved. But if you can, I certainly would not consider discontinuing infliximab on this patient until she's in a long-standing, deep clinical endoscopic biochemical remission.
Absolutely, thank you. And then the other question, how far do I push up the azathioprine? Currently on 75 milligram.
Well, at the moment, that's probably okay because you're just giving it at this point to reduce antibody formation to infliximab. If down the line you find that you're not able to get a biologic for her anymore because of the costing, then you would go to full therapeutic doses of azathioprine, which for her would be about 200 milligrams. There you want to really see a lymphopenia and you want to see a raised NTV, and then you know that you've got therapeutic doses on board. But at this point in time, I think I would just keep her on that low dose, maybe go up to 100, really just to reduce antibody formation.
Okay, so it looks like you've answered my other question as well. So concerns about COVID-19, anything you want to say?
Okay, so none of the medications that we use are contraindications to the COVID vaccine. What vaccine are you using in Ghana?
So we are using the AstraZeneca.
Okay, so that's absolutely fine. The AstraZeneca one is, it's also an adenovirus vector. It's a non-replicating vaccine. It's 100% safe to use in any patient who's on immunosuppressors. And of course, they must definitely get vaccinated. The only issue with that AstraZeneca vaccine is there's some recent data that's just come out, which shows that patients on infliximab, they tend to seroconvert at a much lower rate than patients who are not on infliximab with the first dose of the AstraZeneca vaccine. So it's very important if they get that vaccine that they get their second dose timeously.
Okay, all right. So I think the last one is any suggested plans, I think, which you've already answered. Should we exhaust our current funds for infliximab? And I think you've answered that we should increase the azathioprine to therapeutic doses. And you are recommending for her weight, maybe about 200 milligrams.
But depending on the MTV and the lymphocyte count, you may need to go higher, you may need to go lower.
All right. So thank you very much. I think those were my questions for the case that I presented.
Chris and Mash, do you have any comments on those questions?
I think first I want to say, yeah, thank you for that presentation. This is exactly the sort of stuff that we are looking for, the engagements that we are looking for. And I think the case you presented is fascinating. So thank you so much for that. In terms of exhausting your budget, Jill, would you say biosimilars could be an option?
Definitely, and I hope that they are having them in Ghana and many of our other neighboring countries. I truly hope so, because that will make access better.
Yeah.
Unfortunately, we don't have biosimilars. I think this is true. Johnson & Johnson is only Remicade that is available in Ghana. Probably we'll have to look out for the opportunities for biosimilars so that patients can afford. Because her induction dose actually costs about $5,400.
Sure.
Induction dose alone at a weight of 60 kg.
Yeah.
Okay,
so it might
going to 84 kg, we have a lot of challenge with us in terms of access.
Admittedly, she was a lot thinner when you put her on the infliximab, but maybe going forward in this type of patient where you may want to use adalimumab, where it's obviously a fixed dosing, not weight-based dosing, which would obviously make it sort of cheaper for you down the line, because weight gain is obviously an issue.
Okay, all right. So thanks for the advice.
Mash, there's a question for you here. It says,
do you see it? An answer. And I was just going to say that I would say use the marker that ab initio is the one that is raised. So because patients differ in their response to the different markers. So if calprotectin is up, in the beginning of therapy, then I think that's the one to use for monitoring. Because you're right, sometimes there is a discrepancy between the two. That would be my response. Jill, I don't know if you agree with that.
Yeah, I do agree with that. CRP, of course, is not always a great marker because 25% of patients do not mount a response to CRP. So having a normal CRP at the beginning doesn't always mean that there's not active inflammation. So fecal calprotectin is by far a better marker it's an excellent surrogate for both endoscopic healing and for mucosal healing. So yeah, I think that's the way to go.
Does it correlate well with fibrostenotic disease? Because I think that's where it becomes a little bit.
Well,
Yeah.
if there's, fecal calprotectin is a marker of active inflammation. It's a neutrophil protein. So if you've got active inflammation, it will be elevated. Assumably, if there's predominantly fibrosis in that strictured area, you may still have a raised fecal calprotectin, but it probably won't be as raised as if you've got a roaring inflammatory mass. Yeah.
Yeah.
So it might be used, Jill, as a good predictor of who might respond to an anti-inflammatory agent like a biologic, because the big concern with these fixed fibrotic strictures is throwing a biologic if there's no inflammation, it will really, I mean, I don't think you can expect it to work. So perhaps fecal calprotectin might just be that clue.
Absolutely, Chris. Absolutely.
So yeah, that was excellent, and really, it's an example of what we're looking for in sub-Saharan Africa. We encourage all your colleagues and our friends who we know so well to take over this forum, and these are the kinds of cases we want to hear from. I would also encourage you, please, to make contact with David Epstein, who runs IBD Africa. It's a huge advocacy platform, and perhaps the Ghanaian advocacy group of the foundation that you've obviously precipitated would be in touch with him, because he's looking as well to collaborate with sub-Saharan foundations and raise profile and advocacy.
Thank you very much. I will do that. Thank you.
Well, if there are no more questions, perhaps, Jill, we could close. Yeah,
I think you were going to close, Chris.
Yeah, I'm asking permission.
Yes, you may.
Thanks to the speakers and Amash, excellent presentation. Thank you so much, and Yao, particularly to you for taking the bull by the horns and showing us what is the current situation in Ghana. And really, thank you very much for taking this lead. And thanks also to ECHO New Mexico and the India team. And as usual, there are feedback forms on the chat profile. All these presentations are recorded and are available on our foundation website. Thanks to Karen and Cheryl at the Gastro Foundation headquarters in Cape Town, who put on these meetings every week. And then I really want to pay particular thanks to industry. We have a few sponsors who really are helping us with these sessions. Our platinum sponsor, Takeda, our silver sponsor, Kino, our bronze, Amgen and Equity. And we also encourage our other partners who are really involved with the foundation to also assist us in putting on these meetings every week. So it remains for me to thank Jill for expertise, and to the speakers and to all the participants for taking part today. And thank you very much, and have a good evening.
Thanks, Chris.
Thank you.